Next one, you had 3 days after undergoing an open cholecystectomy, an obese 57-year-old woman has fever, chills, and a headache. She has right-sided chest pain that increases on inspiration and has had a productive cough for the last 12 hours. She had an episode of hypertension after the operation that resolved with intravenous fluid therapy. She underwent an abdominal hysterectomy 16 years ago for multiple fibroids of the uterus. She has smoked 1 pack of cigarettes daily for 17 years. She appears uncomfortable. Her temperature is 39, her pulse is 98, her respiratory rate is 18 breath a minute, and her blood pressure is 128/82. She has inspiratory crackles that you can hear at the right lung base. The abdomen is soft and non-tender, and there's a healing surgical incision below the right rib cage, and the remainder of the examination shows no abnormalities. So which of the following is the most likely diagnosis? So in this case, 3 days post-op, she had an open cholecystectomy, but when you were examining it, it looked like it was healing the wound site. She's obese, she has fever, chills, and a headache, and there's right-sided chest pain that increases with inspiration, and she's had a productive cough for the last 12 hours. So that all points towards, chest infection more than pulmonary embolism because it's a productive cough. And the fevers and the chills and the headache. And she had an episode of hypertension after the operation that resolved with IV fluids, that's fine. She also underwent a hysterectomy, that's okay. She smoker and abdominal surgery in the past, so abdominal hysterectomy and the fact that she's smoking, those are all risks for post-op infection. So that's a post-op lung infection or chest infection. So that also plays in our favor. And then she appears uncomfortable, her temperature is 39, pulse is 98, respiratory rate, that's all fine. And then when you hear it, there's inspiratory crackles, that confirms right there, that's a chest infection, so pneumonia. Because if it was atelectasis, you would have heard, reduced air entry. Subphrenic abscess, abdominal examination would have showed a lot more, and then you wouldn't have heard the right crackles. Congestive heart failure just doesn't make sense, and it would have been bilateral. And pulmonary embolism, again, the fever, the chills, the crackles doesn't explain it. So it really fits with pneumonia. So the patient's clinical presentation is most consistent with post-op pneumonia, common post-surgical complication, presents 3 to 5 days post-op, like in this patient's case. And additionally, this patient has undergone upper abdominal surgery and is a smoker, which are both risk factors for, developing a chest infection. Okay. Next, you had a 62-year-old man who comes to the GP because of a skin lesion on his nose. The patient already, like skin lesion on the face, anything above the neck, head and neck. If you have a lesion on the head and neck, you want to suspect basal cell carcinoma, rule that out first before thinking about your other differentials. But yes, so 62-year-old man comes to the GP because of skin lesion on his nose. The patient has had the lesion for 11 months and has increased in size over the past few months. He's a farmer and lives together with his wife. His mother died of a metastatic melanoma at the age of 67. The patient had smoked a pack of cigarettes daily for the last 30 years and drinks 1 to 2 glasses of whiskey on weekends. His temperature is fine, his pulse is 75, and blood pressure is 140/78. When you examine the lesion, it's a non-tender lesion at the right root of the nose. An image of the lesion is shown. Which of the following is most likely diagnosis in this patient? Again, above 60 with a lesion in the head and neck, basal cell carcinoma until it's ruled out. In this case, yes, he's had a family history of melanoma as well, but that's not how melanoma would look like. It would have the different colors. It wouldn't be raised. It wouldn't be rolled edges like this. This looks like basal cell carcinoma. So this farmer presents with a slowly growing, non-tender, pearly, indurated, nodular skin lesion with a rolled border and a central depression, like a crater, with ulceration on his nose. This is consistent with basal cell carcinoma. It's the most common malignant skin tumor. It rarely metastasizes, and generally it has an excellent prognosis, but if it's untreated, it can cause local destruction. I think they call it rat tumor as well, because it digs into your bones, and like it looks like a rat's taking a chunk of your bone. So it can cause local destruction, infiltration, and it can create significant wound care issues on excision as well. Okay, the next one, you had a An 80-year-old woman who's brought to A&E for left hip pain 30 minutes after she fell while walking around in her room. Her examination shows left groin tenderness. The range of motion of the left hip is limited because of the pain. An X-ray shows of the hip shows a linear fracture of the left femoral neck with slight posterior displacement of the femur. Which of the following arteries was most likely damaged in the patient's fall? So which artery essentially goes around the femoral neck? And it's the circumflex one. I think it's medial circumflex artery. So medial circumflex artery is the one that you find around the femoral neck. Okay, yeah, so the medial circumflex artery is a major branch of the profunda femoris, and it courses medial posteriorly to the neck of the femur, where it supplies blood to the head and neck of the femur. And in a minority of femoral neck fractures, they'll go on to develop osteonecrosis of the femoral head, and those are from injuries to the artery and the small branches to the bone from that artery, from the medial circumflex femoral artery, because you find that around the femoral neck. Okay. Next one, you had a 9-year-old boy who's referred to the hospital because of blurry vision and a headache for 3 months. During this period, the father had noticed that the child's been tilting his head back to look straight ahead. This boy also has difficulty falling asleep for the last 2 months. He has had a 3.5 kilogram weight loss over the past 6 months. His temperature is 37.7 degrees. His pulse is 105. His blood pressure is 104/62. An examination shows equal pupils that are not reactive to light. The pupils constrict when an object is brought near the eye. He has upward gaze. His upward gaze is impaired. There's nystagmus and eyelid retraction while attempting to look upwards. Neurologic examination shows no other focal findings. Which of the following is most likely sequelae of this patient's condition? So what is this patient's condition? So it's a 9-year-old boy. He has blurry vision and a headache for the last 3 months. He's 9 and he has blurry vision and a headache. The father noticed also that he tilts his head back to look ahead. So clearly there's something wrong with his vision. There's impaired vision. Later on we found out, that his upward gaze is impaired. The boy has difficulty falling asleep for the last 2 months, okay? And he's had a significant weight loss of 3.5 kilograms over the last 6 months. It shows equal pupils, not reactive to lights. Pupils constrict when an object is brought near to light, so they accommodate, but they're not reactive. And he has nystagmus and eyelid retraction when looking upwards. But when you do the neuro examination, there's no other findings. So it sounds like he's got some sort of brain tumor that's causing all these symptoms and signs. So in the 9-year-old boy who's not gaining weight and he has all these symptoms, we're suspecting a tumor. The thing that it's most likely to affect is probably, I would have said blindness, but depending on what it is, in a 9-year-old boy with a CNS tumor, it sounds very much like they're more at risk of getting germinomas in their brain, and that releases testosterone, and that can cause an early onset of puberty. So that would be more going with this, in this case, in this scenario, the precocious puberty, because children in their age, if they're going to get a CNS tumor, and it's going to affect like in this case, the vision and everything, it's most likely going to be in the pineal gland, the pineal gland, so piloloma, and usually it's a germinoma, and that secretes beta-HCG, and it stimulates the Leydig cells, and they secrete testosterone, and too much testosterone can cause, an early onset of puberty in boys. Other things that you can get from this tumor specifically is you could get hydrocephalus because it's close, so it could cause hydrocephalus because of obstruction of the CSF outflow, and you can get ataxia if it starts to infiltrate the cerebellum. Okay, and treatment for pinealomas or tumors of the pineal gland, you do focal radiation or chemotherapy. Okay. Next, you've had a 29-year-old nulligravid woman who comes to the GP because of a 10-day history of small quantities of intermittent blood-tinged discharge from her left nipple. There's no personal or family history of serious illness. She smoked 1 pack of cigarettes daily for 5 years. Her last menstrual period was 12 days ago. She's sexually active and uses condoms inconsistently. On examination, there's scant serosandrious fluid that's expressible from her left nipple. There's no palpable breast mass or axillary lymphadenopathy. Examination shows no other abnormalities. Which of the following is the most appropriate next step in management? So the first thing you'd want to do is get imaging And in this case, because she's less than 30 years old, so it would be an ultrasound over mammogram. So because her breast tissue is denser in young women, limiting the efficacy of mammograms, ultrasound is a first-line imaging modality in women less than 30 years of age with focal breast symptoms or findings. Pathological nipple discharge is usually a sign of a lactiferous duct pathology. A subareolar ultrasound will focus on the periareolar region where the lactiferous ducts converge and can detect any ductal abnormalities, whether there's obstruction or dilation elsewhere, whether there's a mass or nodules. And then another advantage of ultrasound over mammogram is, to avoid any